This is a video to help you understand how to do the temporomandibular joint examination, the muscles of mastication and cervical muscle palpation exam, and also the occlusal examination. And I appreciate Eric Holtz, who's a student doctor who's about to graduate, and he's going to help us. And one of the things to understand about this part of the exam is it relies heavily on the patient's own verbal responses. So what we need to do is we need to prepare the patient to be able to give us the responses that are accurate that we need. And because most patients have never had this type of examination before, they're not familiar with it and they don't understand the types of things that they need to report. They have no parameters, so we need to go ahead and calibrate the patient first. And what I do is I'll go ahead and use the patient's hand, because if you're a male doctor like me, hand is usually a safe place, either male or female patient. So I'll just go ahead and take the hand, make sure they don't have some arthritis, and I'm going to take my glove off just for a little while so you can see my thumb bed. And what I'm going to do is, as I press it, you'll see my thumbnail potentially blanch, hopefully, and I don't know if you can see that. But what it'll do is, as it blanches, that's approximately 4 kilograms. So I'm going to press 4 kilograms for 2 seconds, 1,000, 2,000, and that's the type of pressure and the length of pressure that I'm going to go ahead and provide in these palpations. Now I'm going to ask Eric to give me some different responses. And it's very important, and the literature shows that the clinician can very easily bias a patient in this type of examination. That we can either suggest to them that something might be painful, we might suggest to them that there might be referral patterns, and we don't want to do that. So what we want to do is go ahead and calibrate the patient and then give the patient the opportunity to respond as they see fit. So Eric, I'm going to ask you a series of questions, and the questions relate really around 3 different areas. And the first area is I'm going to palpate most of these areas bilaterally. And the reason why I'm going to do that is because that gives you a chance to compare. So as I palpate, say for instance, the superficial masseter muscle in a moment, I'm going to ask you if it's the same on both the right and the left, and that gives you a comparison. Now that question is a good question because it doesn't intonate, nor does it connotate that there's going to be any pain associated with it. In fact, by calibrating the patient's hand first and it wasn't painful, the patient should have no reason to suspect, unless of course they're already reporting to you a specific area that might have pain. So I'm going to ask you that. If one of the areas is different, then I'll ask you to describe whatever sensation there is in a comparison. If Eric does report any type of discomfort, I'll ask him a simple question, direct question is that a familiar pain? Is that a pain that he's ever felt before? And if he indicates yes, then I would even have a follow-up question. Is this part of a complaint or a concern that he's bringing to us today? So that's question number 1. Both the right and left the same. Question number 2 is it a familiar pain? Question number 3 is, when I palpate, whatever sensation that Eric reports, did he feel it just there at the area of palpation, or did he feel it at a distant site? So those are the 3 questions. All right, now we're going to be starting the examination process with the screening of the temporomandibular joint. And what I'm going to do is place my fingers approximately right over Eric's temporomandibular joints. And Eric, I'm going to have you open wide and close, and open wide and close. Go ahead and move right and left and into protrusive. Thank you very much. What I'm feeling right now as Eric is doing this is I'm able to feel the lateral aspect of the condyle, and I can actually feel the movement of the temporomandibular joint underneath my finger. And applying very light pressure, I can tell whether or not one of the condyles or both of the condyles are rotating and translating fully as compared to one to the other. So Eric, I'm going to have you go ahead and open again and close. And now what I'm going to do is I'm going to apply pressure the 4 kilograms for 2 seconds, and I'm going to ask Eric the question. Eric, were both the right and left the same? Yes. Very good. Eric, I'm going to have you go ahead and open wide. And now I'm going to go ahead and come up and in behind the condyle in the posterior lateral area. Were both the right and left the same there as well? Thank you. I'm going to have you turn towards the camera. Go ahead and open very wide for me. And what you'll see, hopefully in the camera, there's a little divot right distal to the condyle. And this is the area that I'm going to palpate up and in. All right, Eric. Eric, thank you. Turn back. Now what I'm doing, go ahead, Eric, turn over this way. What I'm going to be doing now is part of the examination of the joint. I'm going to be providing load testing to the joint. So I'm going to do this in 2 ways, by manual manipulation and also with some tongue blades. Right now I'm locating the angle of Eric's mandible, and I'm going to go ahead and cradle this with my small finger and my ring finger, and the other fingers will go on the border of the mandible. And my thumbs are going to go in a C shape right over the chin. And mostly what I'm going to be doing is I'm going to be lifting vertically right here underneath the angle of the mandible. Go ahead, Eric. Go ahead and open just a little bit. A little bit now. Close just a little bit and let your jaw just relax. As I can feel Eric's mandible rotating in a very concentric and repeatable arc, what I'm going to do now is I'm going to just lift again with the 4 kilograms of pressure vertically at the angle of the mandible. When I did that, Eric, were both sides the same? Conditions, right. Patients won't be able to tolerate that. Either they may be uncomfortable here at the pterygomasseteric sling, or for some other reason. And what I'm going to do now is I'll show you another alternative technique where the patient can go ahead and close down themselves. They can load test their own joints, but having them just bite on 2 tongue blades. Go ahead, Eric. Go ahead and give me a good bite. Great. Thank you. Open. Now, as you did that, Eric, did you feel any discomfort on either side? Great. Let's go ahead and test the other side. Go ahead and close. Great. Thank you. Any discomfort? Both right and left are the same. Thank you. Now go ahead and just close on the anterior section. We'll test both sides at the same time. Thank you, Eric. Anything to report? Now, as the patient bites on the tongue blades on one side, say for instance on the right, go ahead, Eric, what we're actually loading is the contralateral joint. Thank you. Now we're going to go ahead and move now to auscultation. But I'll just say just very quickly before we move to this, that if a patient has discomfort, either at the lateral pole or posterior lateral or during load testing, oftentimes discomfort in the joint is a result of inflammation as a result of degenerative joint disease or other arthritic type conditions. I'm going to go ahead and use the bell-shaped end, and I want to make sure it's open. I'll open it so I know it's open. If we use the flat end, especially on males, we get a lot of crepitus or false positive readings. So Eric, what I'm going to do is I'm going to have you go ahead and open wide and close for me. And open wide and close. Now have you go to the right and to the left. Very good. Now have you go to protrusion and back. Thank you very much. Now you'll notice that while I'm listening on one side, I've got my fingers on the other side, because sometimes you'll actually hear a click, but it's hard to tell which side it's coming from. And by feeling the other side, sometimes you can tell that the click is coming from the contralateral side, even though we're still hearing it over here. And sometimes there'll be clicks on both sides, and sometimes you just have to ask the patient where the click is coming from. So I'll go ahead and do the left side now. Eric, go ahead and open for me. And close, and open, and close, and now go right and left, and into protrusive movement and back. Thank you. Now another note too, if a patient did have a click or a pop, sometimes, especially if it's uncomfortable, they won't open all the way. So as I'm listening, Eric, again, go ahead and open wide, and you can tell Eric's opening quite wide, and we're going to measure that shortly. But I can tell, and I'm watching that, because as the patient's opening, as they get to near their maximum opening, you can tell they'll slow down and they have to strain a little bit, so you can make sure that they're actually opening all the way. Thank you, Eric. Now, as I listened to Eric's joints, I didn't hear any noise. I didn't hear any crepitus. A crepitus is sort of a grinding sound. A click or a pop, which is sort of a staccato sound, like the snapping of a finger, is a disc sound. Another sound that you might hear is more of a clunk sound as the condyle traverses and moves past the articular eminence. The next part of the exam is we're going to be recording Eric's range of motion. This is a very simple but a very important aspect of the examination. And what it does is it shows us very quickly what the mobility and the movement of the mandible is. If a patient has significant dysfunction with their joints or muscles, then we would likely see that in either a decrease in the range of motion or an alteration in the movement. Eric, I'm going to go ahead and just have you open, go ahead and bite down, and what we're going to do is we're going to use tooth number 8 and 25 routinely from examination to examination. So as I go ahead and measure, Eric's got approximately 2.5 millimeters of overjet. Eric, I'm going to go ahead and bite down for me and go ahead and open. And Eric's got approximately the same, or 3 millimeters of overbite. Now, Eric, go ahead and bite down. As we look at Eric's midline, it's slightly off to the left, but it's very, very good. And the mandibular midline and the maxillary midline line up. So now what I'm going to do is ask Eric two things. First of all, I'm going to ask him to open as wide as he can with no discomfort, and then I'm going to ask him to open as wide as he possibly is able to. So Eric, go ahead and open as wide as you can comfortably. And Eric's got a beautiful opening, and he is opening 48 millimeters. Now, as far as measuring the opening, we've also got to include the overbite with the interincisal distance. So we've got to go 48 plus 3. So he's opening 51, which is very good. Typically, if someone opens 51 millimeters, the condyle has translated far enough to traverse that articular eminence. If the patient is opening 40 or more, that's certainly within the range of normal range of motion. If someone's in the range of, say, 25 millimeters, that certainly would be decreased significantly. All right, Eric, now I'm going to have you go ahead now. When you opened up that wide, did you feel any discomfort anywhere? Okay. Now I'm going to have you go ahead and just open as wide as you possibly can. And Eric, you are off the scale. You are at least 70 millimeters. Eric is a true gator, there's no doubt about it. So he's probably 73 millimeters or so. And Eric, I don't know if we'll be able to see anything or not. Go ahead and open as wide as you can, and we really can't see anything. But his condyle has traversed and quite a bit. So thank you, Eric. Now we're going to go ahead and measure the right and left movement as well. And I want to show you an easy way to do this. As we go ahead and look at the midline, go ahead, Eric, and close. The midlines are lined up, so Eric, open just a little bit. Now I'm going to have you go ahead and move your lower jaw, your mandible, to the left as far as it can go. And you can go ahead and try to measure it with your ruler, but a lot of times patients shake and that's very difficult. So what's easier to do is to go ahead and see where the mandibular midline lines up on Eric's lateral incisor. And as I look at that, I can view it pretty quickly. And Eric is moving to the left approximately 14 millimeters, well within normal range of motion. Again, if it's 7 millimeters or greater, it's most likely very normal. Eric, I'm going to have you move over to the right now, as far as you can. And go ahead and bite down again normally. Now open, now move to the right as far as you can. Now to the right, Eric is only able to open approximately 8 millimeters, which is different than the left, which is interesting. So we'll ask ourselves a question about that later. Now, Eric, I'm going to have you go ahead and go into protrusion as far as you can. And Eric, moves approximately 6 millimeters into protrusion plus the 3 again, so he's about 9, which again, very normal. Now, let's go ahead and observe Eric as he opens widely. We're going to be looking for any deviation upon opening. Eric, go ahead and open widely for me. And as Eric does this, we'll go ahead and check it out. He has probably a very slight deviation to the left, maybe a millimeter or so, which is not significant. If it's more than 2 millimeters total, that we would want to record. Go ahead, Eric, and bite down now and go into protrusion as well. Goes straight forward. As he goes to protrusion again, it deviates about a millimeter. Now, Eric, when you moved over to the right, go ahead and move to the right again. Do you feel any discomfort while you're doing that? You certainly are decreased moving to the right as compared to the left. And where do you feel that?
It feels taut right here, like it's being pulled or squeezed.
All right. So Eric is pointing to a superficial masseter, and we'll be palpating that in a little while. But if a patient has difficulty moving one direction or the other, we typically would think of it as either a temporomandibular joint dysfunction, or it could be a muscle that's lost some of its elasticity. So we'll be examining that. And of course, when we were doing our dynamic palpation at first, go ahead, Eric, go ahead and open again and close again. As I felt that with Eric initially, there was a very similar translation on both sides, and certainly with Eric opening 70 plus millimeters, we know those condyles are translating properly. We're going to go ahead now and move on to the muscles of mastication. We're going to use the same palpation technique with 4 kilograms for 2 seconds. And I always do this again in the same order. And I'm going to start with the mid-body, the superficial masseter. Now, Eric, I'm going to have you turn your head again. So a couple of muscles, and just to get our geography and our anatomy right, I'm going to outline both the temporalis muscle and the masseter muscle. So the temporalis muscle is a big thin sheet of a muscle going all the way from the lateral canthus of the eye across the temporal region, all the way even posterior to the auricle of the ear. And it's very, very thin here, but as it gets to the zygomatic arch and below, it's a very thick, muscular muscle, if that's not repetitive. The superficial masseter muscle takes origin on the maxilla, on the zygomatic process of the maxilla, and then it goes inferior and posterior and inserts into the mandible itself all over the angle of the mandible. And we can palpate both the anterior and the posterior borders of it. Now, there's another part of the muscle, or the very vertical fibers of the deep masseter, that we only have one small window, and there's a little divot again, just off the posterior border. Here's the posterior border of the superficial masseter, just anterior to the joint, to the capsule of the joint, and there's a little divot here, and this is the window that we can palpate the deep masseter. So let's go ahead and get started now, and I'm going to ask Eric the same questions as we talked about before. Eric, I'm going to have you go ahead now and move here. Now, as I palpate the masseter, I'm going to do a little light dynamic palpation over the muscles. And in fact, as I do that, I discovered that Eric's muscles feel very taut and very tight, and I'm going to just go ahead and show Eric himself how tight these muscles are. Can I borrow your finger? Now, again, just as a comparison, this is the chin, as we all know, and it's bone and it's very hard. But what's interesting is I'm showing Eric how taut his superficial masseters are, and they're very tight. And ordinarily, muscles should be very relaxed. So as I did this, I actually uncovered an area. In fact, you can see my finger kind of bounce over it. This is a taut band, and it's a hypercontracted area in the muscle that's very tight. And I will palpate that in a moment. So here we go. Superficial masseter. Eric, as I palpate both right and left at the same time, if you would go ahead and report? Were the right and the left the same?
Yeah. They were both the same.
Okay, and how would you describe that as I palpated that?
I would describe it as a mild discomfort, maybe a 2, 2.5.
All right. Now I'm going to go down into the insertion of the masseter and go ahead.
That was more discomfort, maybe 3 or 4.
All right, so mild to moderate. I'm going to do the anterior border.
Left side was more discomfort than the right side was, similar to the insertion.
All right. Now I'm going to go ahead and do the deep masseter, and I'm going to find that little hollow spot right there. And again, both right and left the same.
Similar, yeah.
All right. Now I'm going to move on to the anterior temporalis. I'm going to go 1 digit past the lateral canthus of the eye, and I'll go ahead and palpate right here.
Similar. Equally bilaterally.
All right. Now posterior temporalis, I'm going to find the helix of the ear, and I'm going to go 2 finger widths superior to that. And I'll go ahead and palpate those right there.
Left slightly more than right.
On Eric, we've got a little bit more tenderness on the left side as compared to the right. But what's interesting and important to note is that he's got some top bands both right and left in the superficial masseter and in the anterior temporalis area. I want to provide you with a close-up of the palpation points for the lateral aspect of the face. First of all, Eric, I'm going to have you open wide. As the patient opens wide, the lateral pull of the condyle becomes evident, and we can easily feel it with our finger. Eric, go ahead and close now. As the patient closes, we can follow the lateral pull in order to do our palpation of 4 kilograms for 2 seconds. Eric, go ahead and open wide now. Thank you. Now the lateral aspect of the temporomandibular joint is up and in, and there is a hollow right behind the lateral pull. And as we palpate this region, what we're doing is we're testing the posterior lateral area, which is also called the bilaminar zone. This is the retrodiscal tissue posterior to the joint. I'm going to go ahead and delineate the superficial masseter muscle, which takes origin, as I've already mentioned, in the maxilla, in maxillary, the zygomatic process of the maxilla, and then it goes inferior and posterior into the angle of the mandible. And its insertion is literally right above the angle of the mandible here. And these fibers run in this direction. There's also another section of the masseter, the deep masseter, which runs vertically. To go ahead and palpate the superficial masseter, we'll palpate the very middle aspect of it, which is literally halfway up. We'll palpate the insertion, which is in this region right here, right over the angle of the mandible. We'll also go ahead and palpate the anterior border of the superficial masseter, and then also the deep masseter. And there's a little window, which is literally midway between the temporomandibular joint capsule and the posterior border of the superficial masseter. And there's a little hollow right there, and that is the deep masseter. From here on now, we're going to go ahead and move to the temporalis muscle, which encompasses a broad aspect here of the lateral head. The superficial masseter has very vertical fibers here, and what we'll do is I'll palpate and go ahead and go 1 digit lateral to the canthus, lateral canthus of the eye. Also go ahead and move and palpate the posterior temporalis, which is 2 digits above the helix of the ear. Now there's one muscle that's important, but that the muscles of mastication that we can't palpate, and that's the lateral pterygoid muscle, which is crucial because it's the muscle that moves the mandible both right and left, and bilaterally, it'll cause the mandible to open. And it is too deep to palpate. So what we have to do is we're going to go ahead and use provocation to test this muscle. So Eric, what I'm going to do is I'm going to have you go ahead and protrude your mandible, and I'm going to have you resist me. Now, some instructions are, I don't want you to let me push you back. And especially if a patient had an articular disc displacement issue or one that could be caused, I do not want the mandible to suddenly be displaced distally or in a posterior area, region. So I'm going to go ahead now for 5 seconds. Eric, as I did that, anything to report?
No discomfort.
Right. Now we can also test this muscle too, both the right and the left. Now, it's the left lateral pterygoid that moves the mandible to the right, which I think is one of the reasons why patients get confused when we ask them to move right or left. But that's just the theory. Eric, I'm going to have you go ahead now and move your mandible to the right and resist me for 5 seconds. Anything to report there, Eric? Okay, now I'll have you go to the left and resist me. Excellent. So anything to report there? That's the lateral pterygoid. Now I'm going to go ahead and move on to the cervical musculature, and I'll just discuss these as I go. All right, we're going to take a closer shot here of the palpation of the cervical musculature, realizing how important the cervical musculature is and how the innervation of both the trigeminal system and the C-spine 1 through 4 are very, very closely related neurologically, and therefore referred pain is common. And so here we are. So anatomy, superior nuchal line that runs at the base of the skull. This is the insertion of the trap, which we move down now to the paraspinal area. The splenius capitis is a small window right here on both sides. And then we move down into the anterior trap, and then of course into the sternocleidomastoid muscles there. So as ordinarily the patient would be laying down, but for the insertion of the trap, we would be going up and in here. You want to be just a little careful. The greater occipital nerve traverses through this area, and occasionally you can get a positive from the nerve as compared to the muscle. And then you can palpate the paraspinal area, and as compared to the masseter, you don't feel top bands here. It's very common, but again, we would just go ahead and go up and in. Then we would move down to the anterior trapezius, and again, Eric, like many individuals, has a lot of top bands in his anterior traps, and again, we would go ahead and 4 kilograms for 2 seconds. Now, as Eric turns this way, we're going to go ahead and look at his mastoid process, and this is the insertion. And as you remember, that the insertion is where the muscle inserts, and it's the part that the muscle moves. So in this case, since this muscle, the sternocleidomastoid muscle, rotates the head, this is the insertion, whereas the origin is down on the sternal head to the sternum and the clavicular head to the clavicle. And we'll go ahead and, Eric, I'm just going to have you be straight again, because we don't want to pull this muscle out while you're rotating, because that could be uncomfortable unduly. And then the mastoid process, I'll go ahead and palpate it to the mesial, inferior, and then around to the posterior. And this area certainly refers to the ear and to the top of the head and elsewhere. Sternocleidomastoid muscle is one muscle, interestingly enough, that's been reported to actually refer pain across the midline. Now I'm going to go ahead and let's do some intraoral palpations as well. There are certain muscles and aspects of muscles that we need to palpate intraorally. The first one is the origin of the masseter. The masseter takes origin on the maxilla and on the zygomatic process of the maxilla. Eric, go ahead and open as wide as you can. sometimes this will feel very rope-like right in this area. Eric's is very relaxed. Another muscle is the insertion of the anterior temporalis, and the anterior temporalis envelops or covers the coronoid process all the way down to the third molar area. And the coronoid process is difficult to see. I'm just going to run my finger right up it, and as we palpate this, again as I try to make room for the camera, I'm just going to run my finger straight up the coronoid process, and then I'm going to go medial to it. Eric, would you move your jaw to the right for me a little bit? Give me a little more room. I would go here, and then I would go lateral to it. Now, Eric, would you go ahead and report on that one? I could see by your facial expressions that
Yeah.
was a little uncomfortable.
It was about a 5 pain.
So you're going to have to remember, because now we're going to go to the other side. These muscles ordinarily would be very pain-free. All right, let's go ahead, and I'm going to go ahead and palpate the origin, which I know you can't really see on the left side right now in this video, but again, it feels very similar to the right side. And now I'm going to go ahead and palpate. Go ahead and open wide there. I'm just going to run my finger right up the coronoid process. Go ahead and move. Thank you, Eric. We'll compare this. I went medial, now I'm going lateral. Eric, go ahead and compare the right to the left on this.
Similar
muscle.
level of discomfort. About maybe 4.5.
Now, this is not literature based, but I'll just mention this. This is one muscle that can respond very quickly to splint therapy. Now, the last muscle intraorally is the medial pterygoid, and this unfortunately is an uncomfortable muscle just because of the gag reflex, and I'm going to point to it. Now, the medial pterygoid takes origin where? It takes place between what? The medial lateral pterygoid plate fills that whole space, and then it inserts to the medial aspect of the mandible, which is way back here in the tonsillar crypt. So it's way back here, and I appreciate Eric's being willing to help us out here today, because that's not that comfortable. And Eric will go ahead and compare the right and the left. Now, if you would rate those for me, I would appreciate that.
The left would probably be about a 6, the right about a 4.
So, as with many of the other muscles, the left side for Eric is a little bit more uncomfortable. He self-reports that he clenches more on that side. Whether that's responsible for that, I don't know at this point. But what's important to realize is, along with a lot of muscle discomfort, it is bilateral, even though one side might be greater than the other. Now we're going to go ahead and move to talking about occlusal relationships and interferences. And we're going to go ahead and talk about Engel's classification, which of course is a passive classification. And as we look at the canine, you can see that Eric here is a class 1 canine with the mandibular canine about a tooth width more anterior than the maxillary. The molar, on the other hand, is not classic because the mandibular tooth has a crown on it, and it is slightly more anterior than a class 1, but you would typically think of the mesial buccal cusp lined up with the buccal groove on the mandibular molar as a class 1. Eric, if you'll turn over this way, again, class 1 relationship on the canine, and on the molar, similar situation where the number 19 is a little bit in a class 3 direction as compared to the mesial buccal cusp tip on number 14. All right, so I want to talk about 3 different kinds of interferences. I'm going to go ahead and talk about arc of closure interferences or centric relation interferences. And these conceptually can sometimes be a little bit difficult to think about and to understand. So again, as we go ahead and do the bimanual manipulation, go ahead and tip your head for me. Thank you, Eric. And as we go ahead and look at the arc of closure, and you can see with the bimanual manipulation how Eric's mouth is arcing. And centric relation, by definition, is a mandibular to maxillary relationship. It's a bony relationship, irrespective of tooth contact. And in order for centric relation to exist, you need an intact condylar and articular disc apparatus intact and functioning normally. So we'll go ahead now, and even though it's a bony position, we can check to see if the teeth provide any interferences or if they get in the way of Eric's closure. So we'll go ahead and check that out. Now, Eric, go ahead and just let the teeth tap. Now, can you tell me which area or areas contacted first?
18 and 15 are hitting before anything else.
So now what we'll do is have Eric go ahead and open again a little bit. We really want to get that arc of closure, and really all I'm doing is I'm lifting vertical. I don't want to depress the mandible. I don't want to try to make the mandible do anything. What I would really like to see is just those condyles seated in centric relation, and I want to just see how the teeth match with centric relation. Very good, Eric. Now again, we're going to just let it touch. Now go ahead and squeeze for me. And you can see, I didn't see any slide. So as all of you are watching the video, you can judge for yourself, but it wasn't much if there was any. And for your sakes, that's too bad, because I would like to have you see, a nice slide from centric relation to maximum intercuspation. But you can see that if there was an interference, what it would do is it would interfere with the arc of closure. Now let's go ahead and look at lateral interferences, both working and non-working. Working is so as if Eric moves his mandible to the right and slides, working would be on the right side, non-working or balancing would be on the other side, or contralateral side, and then reverse as he moves to the left. So you could use some shim stock. Instead, I've got some AccuFilm. I'm going to fold it in half just so I can mark individual teeth. Go ahead, Eric. I'm just going to have you close for me, and I'm going to have you slide your mandible to the right. Now stop. And Eric has moved about 1 millimeter, and there is still number 15 and 18 are still contacting. Now, as you heard from your occlusion course, how soon should immediate posterior disclusion occur? My understanding of immediate is right away. So if the patient moves 1 millimeter or 2 millimeters or 3 millimeters, hopefully the disclusion should happen within the first few microns. Go ahead and open. On Eric, the mark of the paper is on the distal buccal cusp. And if you think about it a little bit, potentially an interference that's very close to the first contact might be activated more in a human mouth than one that's way far away. So let's go ahead and check out the left side. Go ahead and bite down, Eric. Now climb up a little bit. Now slide your jaw to the left. Now move. Now Eric on this side had to move almost 3 millimeters before the articulating paper released and before the teeth separated. Now we'll go ahead and we'll check the interference, same place on the distal buccal cusp of the second molar. Go ahead, Eric, go ahead and bite down, and now go ahead and slide into protrusion. Go ahead and open and bite down for me, and slide into protrusion. And on both sides, there's immediate posterior disclusion in the protrusion movement. As a patient, Eric does not have a lot of wear facets in his teeth. But as you remember, he did have a balancing interference on the right side. As he moved to the left, the non-working or balancing side actually did not release immediately. In fact, as we look at tooth number 31 here, as I keep it dry with the air syringe, we'll see on the distal aspect of 31, really on the marginal ridge, that there is a wear facet both directions, both up the distal buccal cusp and on the distal lingual cusp. He actually has both a working and a non-working interference back there. And you can still see some of the carbon paper mark, but there is a flattened section right there in that distal buccal cusp. Which raises the question, how important are interferences? Do interferences cause problems on every patient? And the answer seems from literature and even from common sense to say no. So how would we decide whether interferences or some of these occlusal situations would be important or not? And I would just submit to your own thinking that we want to see if there's any adverse consequences to these interferences. So for instance, if this tooth had a crack back here, we might think, okay, maybe those interferences were important. If the tooth was mobile, and this tooth is not mobile, doesn't move one bit, it's perfect. If the tooth was severely worn, if the tooth were fractured, if the tooth had a very steep area of a periodontal defect, if there were signs and symptoms associated with the interference, then we might be concerned. If there are no signs or symptoms, then I would suggest to you that we don't need to be that concerned right now. So at this point, this concludes the examination. The physical exam has other aspects as well, but that's the part we're going to cover today. So thank you very much.